We'll be breaking down all major concepts covered on the exam. Hello and welcome to this review session. I'm Arvi.
And I'm Donna. We are your MCCQE reviewers, and our mission today is to help you feel significantly more comfortable and confident with the exam review process.
Setting the stage for our deep dive today, the concepts we are covering come directly from reliable StatPearls articles, but we do need to put out a quick disclaimer up front.
Right, yeah. This review is strictly for medical education, not medical advice. Any actual clinical decisions, they need to involve a qualified healthcare provider.
Exactly. So, diving right into section SO5, renal medicine, our focus today is the prostate. We're going to be unpacking two really distinct pillars.
Benign prostatic hyperplasia, so BPH and prostate cancer.
Yeah, and it's wild. You have this organ, right? It's the size of a walnut, yet it dictates the sleep schedule of millions of men.
Oh, absolutely. And it creates some of the most dangerous clinical traps on your exam.
Yeah.
I mean, you are dealing with PSA-level interpretations, specific anatomical zones that dictate pathology.
Tricky medication timelines.
Yes. And just a whole lot of plumbing issues in general. That tiny gland, functionally and pathologically, punches way above its weight class.
It really does. So let's start with the most common issue associated with aging, right? The benign beast itself.
BPH. It gives us a great baseline for what happens to the gland as men get older, well before we even, introduce the concept of malignancy.
But terminology seems to be the first big hurdle here. The exam just throws acronyms around. And if you don't know the precise differences, you can get tripped up before you even finish reading the question.
Yeah, that's a classic trap. So let's break it down. BPH, benign prostatic hyperplasia, that strictly describes the microscopic histological changes.
Right, the actual cellular proliferation.
Exactly. And you have BPE, benign prostatic enlargement. That's the physical macroscopic increase in the size of the gland caused by that hyperplasia.
Makes sense. And finally, BUO.
Right, bladder outlet obstruction. That is the actual clinical plumbing problem where the urinary flow is blocked.
So BPH leads to BPE, which leads to BOO.
You got it. And the pathophysiology bridges those concepts perfectly. The hyperplasia happens because of an imbalance between cellular proliferation and apoptosis.
Meaning programmed cell death.
Right. The cells simply stop dying off at a normal rate, so they just keep multiplying. And this specific overgrowth happens almost exclusively in the transition zone of the prostate.
The transition zones, that's the periurethral area, right? The part wrapping directly around the urethra.
Exactly. That location is the whole reason it causes symptoms. And this overgrowth is heavily driven by dihydrotestosterone, or DHT.
Okay, so the prostatic stromal cells, they use the enzyme 5-alpha reductase to convert circulating testosterone into DHT.
Right, which essentially acts as this high-octane fuel for the cellular overgrowth.
And the epidemiology really reflects just how potent that fuel is. I mean, histological evidence of BPH shows up in 50 to 60% of men in their 60s.
And it skyrockets to up to 90% by age 70.
Wow, up to 90%, so it's incredibly common.
It is. And visualizing this obstruction really helps clarify the clinical picture for the exam. I like to think of the urethra as a garden hose.
Okay, a garden hose. Let's run with that.
So BPH obstructs that hose in two distinct ways. First is the static component.
The physical bulk.
Exactly. The sheer physical bulk of the enlarged prostate acts like a heavy tire parked directly on top of the hose. It's just crushing it from the outside.
Okay, so that's the static component. What's the second?
The dynamic component. See, the prostate contains a vast network of smooth muscle. And due to baseline sympathetic tone, that muscle can clamp down tight around the urethra.
Kind of functioning like a hand aggressively squeezing the nozzle of the hose.
Perfectly said, yes. The tire and the ham.
Right, and our treatments eventually target those exact two mechanisms. But, patients don't walk in complaining about their sympathetic tone.
No, they definitely don't. They come into the clinic complaining about lower urinary tract symptoms.
LUTS?
Right. And we divide LUTS into two categories for the exam: storage symptoms and voiding symptoms.
Let's start with storage.
Storage symptoms occur when the bladder becomes chronically irritated. I mean, it's constantly having to push against this physical obstruction. So the bladder muscle hypertrophies.
It gets really thick and twitchy.
Exactly. And this manifests as frequency, nocturia, which forces the patient to wake up multiple times a night to pee and intense urgency.
Man, nocturia alone sounds exhausting. And then you have the voiding symptoms.
Right, which are the direct mechanical result of the blockage itself. The patient experiences hesitancy trying to start the stream, a noticeably weak urinary stream once it finally gets going, and this lingering sensation of incomplete emptying.
Okay, so a patient walks in, totally exhausted from getting up 5 times a night. We need a very specific high-yield diagnostic workup for the MCCQE.
Always start with a digital rectal exam, or DRE.
Right. And with BPH, the prostate should feel smooth, rubbery, and symmetrically enlarged.
Exactly. A hard, nodular, or asymmetric prostate immediately shifts your clinical suspicion away from BPH.
Heavily toward cancer.
Yes, exactly. Following the physical exam, a urinalysis is absolutely mandatory. You must rule out a concurrent urinary tract infection or microscopic hematuria.
Because hematuria in this context could point to bladder stones, right? Since they form due to urinary stasis.
Right. Or it could be something much more sinister, like bladder or prostate cancer. Once the urine is clear, you administer the IPSS or AUA symptom score questionnaire.
To quantify the patient's actual burden.
Yeah. A score of 10 or higher is the general threshold indicating you really need to initiate active treatment.
And we also need to objectively measure the plumbing issue by checking the post-void residual, the PVR, right?
You do. You use a bedside bladder ultrasound right after the patient voids. A normal PVR is less than 100 to 150 milliliters.
You can also measure their peak urinary flow rate. A flow rate of 13 cc per second or greater is considered acceptable.
Yep, that's spot on.
But wait, let me push back on this whole medical approach for a second.
Go for it.
If a patient comes in with this massive 80-gram prostate physically crushing the urethra, why are we bothering with pills?
Because it's less invasive.
But if we have a structural physical blockage acting like a tire on a hose, it seems logical to just operate and remove the obstruction entirely, doesn't it?
Well, surgery seems like the obvious mechanical fix, sure. But medical therapy is highly effective, vastly less invasive, and carries far fewer risks than going into the urethra with a resectoscope.
Okay, fair.
Yeah.
What are the surgical risks we're avoiding?
Oh, things like general anesthesia complications, severe bleeding, retrograde ejaculation, and urethral stricture. They're significant risks. So instead, we utilize a medical ladder, specifically engineered to target those static and dynamic components you outlined earlier.
Got it. Okay, let's tackle relaxing the nozzle first, addressing that dynamic component driven by smooth muscle.
Alpha blockers are your first-line defense here. Medications like tamsulosin or alfuzosin.
They block the alpha-1 receptors, right, which directly relaxes the smooth muscle in the prostate stroma and the bladder neck.
Exactly. And they are incredibly fast-acting. Patients typically experience maximal symptom relief within 72 hours of taking that first pill.
That's amazing. But I know the exam loves to test the specific side effect profile of these drugs, particularly the massive trap surrounding cataract surgery.
Oh, the floppy iris syndrome. Yes, this is a huge exam point.
Right. So alpha blockers cause this floppy iris syndrome because the dilator muscle of the iris also relies on alpha-1 receptors to maintain its tone.
Yeah, so if you block those receptors systemically, the iris becomes flaccid. It can actually prolapse out of the surgical incision during a cataract extraction.
Which is a disaster for the ophthalmologist.
Total disaster. Coordinating with the patient's ophthalmologist before starting these meds is absolutely crucial.
Okay, so that's the hand on the nozzle. What about moving to the static bulk, the actual physical crushing of the hose?
For that, we use 5-alpha reductase inhibitors, or 5-ARIs, medications like finasteride or dutasteride.
Right, which block the enzyme converting testosterone to DHT.
Exactly. Without that DHT fuel, the prostate cells are essentially starved. It induces widespread apoptosis, and over a period of months, this structurally shrinks the volume of the gland.
But the clinical caveats for 5-ARIs are huge on the exam. They only show significant clinical benefit if the prostate is already substantially enlarged.
Right, typically defined as over 30 grams on imaging.
Plus, they require real patience. It takes up to 6 months of continuous daily use to reach their maximal effect and actually relieve the obstruction.
Yes, but here is the single most vital exam trap regarding 5-ARIs. It involves the PSA test.
Right, the PSA.
Because these medications physically destroy glandular tissue, they reduce serum PSA levels by approximately 50%.
Wow. Okay, so if a patient has been on finasteride for a year and their routine PSA comes back at 2.5...
You must mentally double it to 5.0 when evaluating their risk for prostate cancer.
That's a massive trap. Forgetting to double that number means you are interpreting a falsely reassuring lab value. You could potentially miss a hidden malignancy.
Exactly. Do not forget to double the PSA for patients on a 5-ARI.
I also want to highlight a clever pharmacological 2-for-1 option here.
Oh, Tylofil.
Yeah, if a patient is dealing with BPH symptoms and also happens to complain of erectile dysfunction, you can prescribe a daily PDE5 inhibitor, specifically 5 milligrams of tadalafil.
Right, because it improves blood flow and relaxes smooth muscle in both the prostate and the penis. You address both complaints with a single prescription.
It's elegant, but unfortunately, pills manage the chronic condition well, but sometimes medical therapy fails, or patients just ignore their symptoms until things go from bad to worse.
And that lands them in the ER in absolute agony with acute urinary retention, or AUR. The presentation is really unforgettable.
Severe lower abdominal pain, a palpable, painfully distended bladder.
And a complete inability to pass even a drop of urine.
The immediate move in the ER is Foley catheterization to relieve the pressure. Right?
Yes, immediately. But there's a persistent myth out there that suggests you should clamp the catheter periodically during drainage to prevent bladder spasms or sudden hemorrhagic cystitis.
Right, I've heard that. Is it true?
No. Current urological guidelines state definitively that there is no benefit to clamping. You just let the bladder drain freely and completely.
Good to know. So setting the patient up for a successful voiding trial without the catheter requires a bit of pharmacological support in patients.
Yeah, you start them immediately on an alpha blocker, typically high-dose tamsulosin, and you must leave the catheter in place for at least 72 hours.
Because it takes 3 full days for the medication to reach peak efficacy and relax that bladder neck.
Exactly. And more importantly, that severely overstretched detrusor muscle in the bladder wall needs time to recover its contractility.
Which brings up a great point. The volume you initially drain gives you a huge clue about that muscle's potential to recover, right?
It does. Draining 500 to 1,000 milliliters usually means the muscle tone will bounce back.
But if the retention volume was massive, anything over 1,000 to 1,500 milliliters,
Then the detrusor muscle fibers have been stretched well beyond their physiological limit. Recovery is poor, and the patient is highly likely to fail the voiding trial when you pull the catheter.
and failing that voiding trial or experiencing intractable LUTS despite maximum dual medical therapy, that pushes the clinical pathway towards surgical intervention.
Yes. The gold standard procedure for decades remains TURP, transurethral resection of the prostate.
Where a urologist uses a scope to systematically core out the obstructing transition zone tissue, just carving out a wide-open channel for urine to flow.
Right. But standard TURP has limitations, especially regarding operative time and bleeding risks when dealing with massively enlarged glands, anything over 80 to 100 grams.
So for those massive prostates, you'd look at newer modalities, like HOLIP, holmium laser enucleation of the prostate.
Or aquablation, which utilizes a robotic, high-pressure water jet to map and destroy the excess tissue. These provide safer alternatives with shorter recovery times for huge prostates.
So up to this point, we've been talking entirely about the transition zone, the central area suffocating the urethra.
Right, but if we shift our focus to the outer edge, the peripheral zone, the cellular behavior changes drastically.
The cells there react to aging and genetic mutations in a much more dangerous way. Which brings us to prostate cancer.
And it's so vital to separate these two distinct disease processes. BPH does not degenerate into cancer.
They simply share the same organ.
Exactly. And because cancer originates on the outer periphery, it doesn't typically compress the urethra early on.
Right, so LETS only manifests in the very late stages when the malignant tumor has actually grown large enough to invade the central structures.
Which is why screening is so important. Identifying the patients at highest risk requires looking at three major factors. First, age drives incidence. Finding prostate cancer in a man under 45 is exceptionally rare.
Second is ethnicity, which heavily influences outcomes. African American men face the highest incidence and mortality rates globally.
And third, genetics act as a massive force multiplier. Inheriting mutations like BRCA1, BRCA2, or having Lynch syndrome, those profoundly elevate a patient's lifetime risk of developing aggressive disease.
And the clinical approach to finding this cancer brings us to the endlessly debated PSA screening controversy.
Oh, the USPSTF guidelines. They advocate for an individualized, shared decision-making approach for men aged 55 to 69.
Because the conversation must heavily weigh the burden of overdiagnosis, right? Finding a microscopic indolent cancer often leads to biopsies and surgeries that cause impotence and incontinence.
Exactly. You could effectively ruin a man's quality of life for a tumor that may never have harmed him. Which is also why routine screening for men over 75 is actively discouraged.
Because finding a slow-growing cancer at that advanced age rarely alters overall mortality.
Right. But interpreting a PSA lab value, it goes far beyond just looking at the raw number. We have to analyze the kinetics.
Like PSA velocity, which tracks how fast the number is rising, an increase exceeding 0.75 nanograms per milliliter per year demands investigation.
Or PSA density, which divides the PSA value by the physical volume of the prostate on imaging.
So a density greater than 0.15 suggests the PSA is coming from a dense cluster of malignant cells rather than just a benign, bulky gland.
Exactly. Let's put this into a clinical scenario.
Okay, hit me.
A 60-year-old patient has a slightly elevated PSA of 6. Sticking hollow needles through his rectum into his prostate for a blind biopsy carries serious risks, like sepsis and rectal bleeding.
So we need better ways to risk stratify before pulling the trigger on a biopsy.
Yes. The landscape has completely shifted away from blind biopsies.
Hmm?
Multiparametric MRI of the prostate is now a foundational diagnostic tool.
Using the PI-RED-C scoring system, right, the prostate imaging reporting and data system to categorize suspicious lesions.
Right. A PI-REDS 1 or 2 is overwhelmingly benign. A 4 or 5 is glaringly suspicious and absolutely mandates a targeted biopsy.
But the absolute nightmare scenario for clinical decision-making is the PI-REDS 3.
Oh, it's totally equivocal.
Right. You can't just ignore it and send the patient home because a PI-REDS 3 lesion actually hides clinically significant intermediate or high-grade cancer about 20% of the time.
So breaking that tie requires risk stratification bioassays. These are advanced urine or blood tests like the PCA3 4K score or exosome test.
And they basically hunt for specific genetic markers and RNA fragments shed by aggressive prostate cancer cells.
Exactly. If the bioassay indicates high genetic risk, you proceed to the biopsy. If it's reassuringly low risk, you can safely avoid the needles and place the patient on active surveillance.
Just monitoring their MRI and PSA over time.
Right. But when the imaging and bioassays force our hand, a urologist performs an MRI ultrasound fusion biopsy.
Blending the MRI images in real time with an ultrasound probe to hit the exact suspicious lesion.
And that tissue goes to the pathologist who grades the malignancy using the Gleason scoring system.
Now, unlike most other cancers where pathologists hunt for specific intracellular mutations or mitotic rates, the Gleason score evaluates the architectural chaos of the glandular tissue.
Chaos is the right word.
I always picture this like evaluating a residential neighborhood from an airplane.
Okay, I like this analogy.
A Gleason pattern 1 is a perfectly planned subdivision. All the houses, or in this case the glands, are uniform, well-differentiated, and neatly separated by stroma.
But as the cancer gets more aggressive, the architecture degrades. By the time you reach a pattern 5, a hurricane has hit the subdivision.
Exactly. It's just a totally disorganized pile of bricks with zero recognizable glandular structure.
So the pathologist surveys the entire biopsy core and identifies the most predominant architectural pattern, followed by the secondary most common pattern.
And they add those two numbers together to generate the final Gleason score.
Which is crucial, because the math here dictates the entire trajectory of the patient's treatment.
Let's do the math. A biopsy showing a predominant pattern 3 and a secondary pattern 3 equals a Gleason 6.
This is well-differentiated, low-risk cancer.
But the danger escalates when pattern 4 appears. A 3 plus 4 equals 7, representing intermediate risk, but a 4 plus 3 also equals 7.
And that simple mathematical flip changes the diagnosis to high-grade disease, because the predominant driving force of the tumor is the more aggressive pattern 4 tissue.
It's such a critical distinction. So managing localized disease, meaning cancer that has not breached the prostatic capsule, depends heavily on that Gleason math.
For low-grade, low-volume disease like a Gleason 6, active surveillance is the gold standard. We intentionally do not operate or radiate.
We just monitor the patient meticulously with serial PSA checks and repeat biopsies every 12 to 18 months. We only intervene if the architecture downgrades or the tumor volume expands.
Right. But patients requiring definitive therapy for higher-grade localized disease choose between radical prostatectomy, surgically excising the entire gland, or radiation.
Delivered either via external beam or implanted radioactive brachytherapy seeds.
And the overall 10-year survival rate for surgery versus radiation is virtually identical.
Really? So how do they choose?
The decision hinges entirely on the side effect profile and what the patient's willing to tolerate. Removing the prostate surgically threatens the cavernous nerves and the external urethral sphincter.
So carrying higher immediate risks of erectile dysfunction and stress urinary incontinence.
Exactly. Radiation avoids the knife but damages surrounding tissue over time. This leads to radiation cystitis, rectal bleeding from proctitis, and a gradual, slower onset of erectile dysfunction as the local blood vessels scar down.
Wow. But, tumors don't always stay confined to the subdivision.
No, they don't.
When aggressive high-Gleason cancer escapes the capsule and invades the pelvic lymph nodes or metastasizes to the axial skeleton, localized treatments like surgery and radiation become basically futile against a systemic problem.
Right. Advanced disease requires systemic chemical warfare. Prostate cancer is exquisitely sensitive to testosterone.
It relies on the androgen receptor to drive cellular replication.
So androgen deprivation therapy, or ADT, starves the cancer of this fuel. It causes widespread tumor apoptosis and actually shrinks bone metastases.
And while surgical castration via bilateral orchiectomy achieves this instantly, most patients opt for medical castration.
Which involves manipulating the hypothalamic pituitary gonadal axis using two main classes of drugs, LHRH agonists and antagonists.
The mechanism of action here is a classic high-yield exam concept. LHRH agonists like leuprolide initially overwhelm and overstimulate the pituitary gland.
Right, and that massive overstimulation triggers a massive release of luteinizing hormone and follicle-stimulating hormone. The testes respond by pumping out a huge surge of testosterone.
Wait, a surge?
Yeah. It takes a few weeks for the pituitary receptors to finally exhaust themselves, downregulate, and completely shut off production.
Ah, so that initial testosterone surge causes that dangerous phenomenon known as a tumor flare.
Exactly. The sudden influx of fuel causes the bone metastases to rapidly expand, leading to excruciating skeletal pain or even catastrophic spinal cord compression.
So initiating an LHRH agonist absolutely requires co-administering an anti-androgen medication like bicalutamide for the first few weeks.
Yes, to physically block the androgen receptors and protect the patient from the flare. LHRH antagonists, on the other hand, medications like Degerelix or Relugolix, they bypass the overstimulation phase entirely.
They bind directly to the pituitary receptors and shut them off immediately.
Right. There's OLH surge, no testosterone flare, and serum testosterone plummets to castrate levels within days.
But wiping out a man's primary sex hormone essentially induces sudden, severe menopause. Managing the fallout of ADT requires proactive medicine.
Definitely. Patients suffer from intense vasomotor symptoms or hot flashes, which we can manage with SSRIs like venlafaxine or progesterone analogs like medroxyprogesterone.
And the most insidious side effect is profound osteoporosis. Stripping the body of testosterone rapidly leaches calcium out of the skeletal system.
The exam requires you to know this. Any patient expected to remain on ADT for more than 1 year must undergo a baseline DEXA scan to evaluate bone mineral density.
Followed by a surveillance scan every 2 years.
Yes, and you counteract this accelerated bone loss by aggressively supplementing with calcium and vitamin D.
And if the DEXA scan reveals a dropping T-score, you must initiate therapy with a bisphosphonate or denosumab to fortify the bones and prevent devastating pathological fractures.
Right, but despite our best efforts to starve the cancer, malignant cells are highly adaptable. Eventually, almost all advanced prostate cancers mutate their androgen receptors or begin synthesizing their own intracellular androgens.
So the disease progresses despite blood testosterone remaining strictly at castrate levels.
Which is defined as less than 50 nanograms per deciliter.
Crossing into castrate-resistant prostate cancer opens up an arsenal of advanced targeted therapies, though. Like, patients suffering from painful osteoblastic bone metastases benefit heavily from radium-223.
Because radium mimics calcium chemically, it is absorbed directly into the areas of rapid bone turnover surrounding the metastases,
delivering highly localized, destructive radiation while sparing healthy marrow.
Exactly. And genetic profiling of the tumor unlocks even more precise weapons. If the cancer harbors a BRCA mutation, we deploy PRP inhibitors like olaparib.
Because these drugs exploit the cancer's pre-existing inability to repair double-strand DNA breaks, it forces the malignant cells into apoptosis while sparing healthy tissue.
It's brilliant. And the ultimate frontier in staging and treating advanced disease revolves around prostate-specific membrane antigen, or PSMA.
This protein is heavily overexpressed on the surface of prostate cancer cells, right?
Yes. We perform PSMA PTCT scans by attaching a radioactive tracer to a PSMA-binding molecule, allowing us to visualize microscopic metastases anywhere in the body.
And then we can swap the harmless imaging tracer for a highly destructive radioactive isotope like lutetium-177.
Delivering a lethal dose of targeted radiation directly to the cancer cells, regardless of where they are hiding.
Incredible. Summarizing this massive landscape, you really have to keep the zones straight for the exam. The transition zone brings us BPH, which we manage with a dual-threat medical approach.
Alpha blockers relaxing the dynamic smooth muscle and 5-ARIs slowly eroding the static bulk.
And moving to the peripheral zone brings us cancer. You navigate the complex screening math of PSA kinetics, the architectural grading of the Gleason score, and the systemic hormone-starving tactics of ADT for advanced disease.
It's a lot to keep straight, but it all follows a logical progression.
Before we wrap up, consider where this field is heading. We are uncovering more about germline mutations like BRCA and ATM that rigidly dictate a patient's susceptibility to aggressive prostate cancer.
Right.
Could we eventually see a future where personalized genetic vaccines train a patient's immune system to recognize and hunt down these specific markers years before a tumor ever forms?
It's a fascinating thought. We might be looking at a future that completely eliminates the need for radical surgeries, radiation, and chemical castration simply by vaccinating against the patient's own genetic destiny.
The pace of innovation in targeted oncology suggests that kind of truly personalized medicine is closer than we think.
It really is.
But you still have to master the mechanics of the garden hose, the anatomical zones of the walnut, and the architectural grading of the bricks to pass your boards today. Keep reviewing, keep connecting the clinical dots, and keep crushing your MCCQE prep.